for his presentation.
Thanks very much, Rebecca. So I was invited by the School of Primary Care Researchers to give a quick overview of the Research Patient Benefit Programme, which I'm a Senior Research Manager on and I lead commissioning on. So on today's meeting, I just want to go through the RfPB programme, go through its scope, the funding limits, and mention some of the opportunities we have for early career researchers and the future initiatives and opportunities in the programme. And then I'd just like to go through some example case studies we have, and then signal you into what looks like a good application and where you can go for help if you're interested in applying. So to start off with, I don't know how many of you will even be familiar with the RfPB programme, but we are one of the 8 NIHR funding streams. We're a response mode funding programme and we accept grants up to £500,000 and we operate a tier funding limit system. So we sort of categorize the applications we receive according to 3 funding tiers, so we can get an idea of value for money. So the highest of these is tier 1, which goes up to £500,000. We then have a level below that, tier 2, which is for feasibility applications that can come up to £300,000. And then we have more upstream studies which can cost up to £200,000, which come in at tier 3. We run 3 funding competitions a year and we receive about 130 applications per round. And we operate on a regional model, and we're actually unique in the NIHR for doing this. So we operate 8 regions across England, from the northwest and Yorkshire and northeast all the way down to southeast central and the southwest. And to date, we've made around 1,400 awards, totaling nearly £313 million in funding contributed. And we're actually one of the nicer programs, I suppose, in the group, in that we have a success rate of about 22%. So by all means, worth a shot. You're almost 1 in 4 of getting your project funded, providing it's good. And really, the one thing that I want to hammer home throughout the whole of this webinar is that when we receive projects and applications to RfPB, the main thing is that projects need to have a clear trajectory to patient benefit. And you'll hear me say this quite a few times, and the clue's in the name of research for patient benefit. But this is one of the big things when crafting your application, when writing it, when submitting it, and when thinking about what you might submit. So as I mentioned, we have those 8 regions. Each one has its own committee chair, who is an expert in their field, and then we have a program director, Professor Kevin Monroe, and each region has its own dedicated research manager who manages the commissioning and smooth running of those regional funding committees. So what do we fund? The short answer is basically everything, if you can provide a realistic trajectory to patient benefit. So overall, studies which evaluate the provision and use of NHS services, evaluations of innovations and developments, including things like novel interventions, feasibility studies and research requiring follow-on awards from other funders, development and refinement of new outcome measures and scales, and then as well needs assessments, evidence synthesis, systematic reviews, methods development and exploratory studies. Really, really broad scope. It's probably easier to focus on the things that we won't fund, and usually these are often either due to the smaller funding amounts of RfPB or due to that sort of concern about patient benefit and the trajectory. So we won't fund laboratory-based research or basic science research, infrastructure such as setting up or maintaining research units. I don't think you'd get very far with £500,000 in that respect. Applications which are solely service developments unless they have a wider generalizability. Those which are only adult audits or surveys, although they can sort of be part of a larger piece of work which could come into RfPB, and then applications which are primarily concerned with setting priorities for future directions of research, although again, potentially that could form part of a wider application. So as you can see, half of these are due to things that, you know, where that trajectory to patient benefit is just too far for us to commit funding to it, and some of them are actually just due to the fact that you simply wouldn't be able to set up an infrastructure with a £500,000 grant. So as I was mentioning, with our funding limit guidance and our tier system of funding, our maximum amount that we would commit to funding is £500,000, and that would be up to 36 months of work. And we use a tiered funding strategy to balance the likelihood of a proposal achieving patient benefit against its cost. So as I mentioned before, that tier 1 cost right up to that £500,000 limit would be proposals with a clear trajectory, a clear and close trajectory to patient benefit. So these could be randomized controlled trials or diagnostic accuracy studies, or even target trial emulation. Basically, the best way of thinking about it is if the results of the proposed work could directly lead to a change in routine patient care, then that could come in at tier 1. If it requires maybe one extra bit of research, so maybe a full trial to confirm findings, so if you're planning a feasibility or a preparatory study, that could come at the tier 2 £300,000 limit, and then the tier 3, those ones are the ones that require 2 or 3 projects to sort of build on those fundings, to build on the work that is done in your project. So those are the ones that's higher risk, more exploratory proposals, and just have that longer trajectory to patient benefit. So when you're thinking about what work you might be incorporating in your application to RfPB, think about how much work needs to build on it, and that should guide which research tier you should be aiming for in your application. So in terms of that tier 3 level of funding, as I said, it's quite broad. It's based on the fact that quite a lot of extra work will be needed in doing it. So in terms of our examples of things that we would see in tier 3, quite routinely, we get observational studies using clinical databases. So a lot of CPRD based studies come through in tier 3. Developing and refining interventions, scales, outcome measures. We also get exploratory studies, secondary data analyses. We also get follow-up for a phase 4 clinical trial, so additional follow-up from once a trial is finished. And then also systematic reviews where the number of relevant studies is likely to be limited. So often those will all come under that sort of tier 3 umbrella. And also, I just want to highlight, I think, especially for you, as I assume a lot of you will be fairly inexperienced researchers and early career researchers, we really encourage applying to RfPB. So within the NIHR, we actually probably offer the best opportunity for early career researchers to act as a lead applicant. We don't when we view a research team in an application, we look at that team of investigators as a whole. We don't usually sort of focus on a lead applicant being uniquely inexperienced. As long as the experience exists within the whole team, then that will be looked favorably on by our committee. So this could be a really, really good opportunity for you to submit an application and lead on and get an opportunity to lead on your first grant. So actually about 50% of our funded applications are actually led by an early career researcher. So by that definition, someone who has not yet been PI for a substantial award. And actually, when we invite early career researchers to apply, the only thing we ask for is that you're accompanied by an experienced joint lead applicant. So a senior colleague who can sort of fulfill that role as a mentor. And then within your application, as long as you can provide a clear justification as to how that joint lead applicant will provide mentorship and provide guidance for you as an early career researcher, then that is likely to be accepted by our committee. And just sort of underline that point of us being friendly to early career researchers. When we've sort of like looked through the numbers over the past 5 years, I think, of the programme, and actually the success rates for those applications that come through by sole lead applicants, so as a proxy for those who are probably more experienced, and those that come through as joint lead applicants, so those who are more than likely an early career researcher bringing on a joint lead as a mentor. Actually, the success rate for those ones that have joint leads are actually about equal, and sometimes above in various years of the last 5 years. So you have a really good chance, as long as the application is strong, and I think the rest of the research team is there. You certainly won't be disadvantaged for being an early career researcher in applying to this program. So just to take you through, we're also sort of running some new initiatives in the program at the minute. So one of these is a series of highlight notices looking at underrepresented disciplines and specialisms. So essentially, we've sort of been, we were at one point we did an exercise in about 2022 where we were looking at the applicants who were coming through to our program and seeing, the the academic background, the disciplines and specialisms of those applying, and we noticed that there were a lot of groups that simply weren't applying in numbers that we might like to see. So we ran a series of highlight notices specifically targeting certain specialisms, groups, disciplines to really boost their numbers and encourage them to apply to the program in future. So to date, we've run 3 of these. So we've run nurses and midwives, a specific group for them. At that point, we received 99 applications in a single call and funded 16 applications. And I believe all 16 of those have actually now started. We then ran a subsequent one for methodologists so that they could lead on applications, as quite often methodologists are relegated to co-applicant status. And again, that was really popular. 119 applications received and 25 funded. And then most recently, we've done an allied health professionals call, which I believe wrapped up in about November. For that, we received 101 applications and 58 were invited to stage 2. And we're just, we've had the funding recommendations and we're just getting sign off for those. And then in future, we're also running a call for other registered health professionals, which is essentially anyone who wasn't covered by those first 3, so quite varied. And that call launched in November, so we'll be having our committee meetings later in the year this year. And the main aim was to support underrepresented disciplines to lead research awards and strengthen their research careers. So not just be part of a team, but actually get a chance to be that lead applicant, form their own research application, and get that experience of submitting and applying for funding. So each highlight notice, if any of these do interest you or do interest you in the future, they all have slightly different eligibility criteria. So in some cases, we sort of mandated that, so for the nurse and midwives one, that one had to be led by an early career researcher. For others, that didn't apply. And for the methodologists, for example, we had applications from higher education institutes rather than NHS trusts. So in terms of future plans and initiatives, we've also launched our regional priorities highlight notice. So these are ones that invite applications that specifically address regional needs and priorities. That's sort of running on a staggered rollout. So we're starting off with the East of England and South West with our competition 56. In competition 57, it will be West Midlands and East Midlands, and then rolling out to the other 4 regions in the subsequent 2 competitions. So these would always be under scope of applications that solely focus on priorities that are regional in nature, but we really just want to exploit our regional funding model. We have separate committees of experts from each of these regions, and they're best placed to sort of make an assessment on how relevant these are. So we're excited to see how that goes. And then we're also sort of broadening our approach to PPI, and in future we're expecting that PPI activities are reported on in peer-reviewed publications alongside scientific fundings. This is based on a review of the publications that came through from our awards, and we've been really looking to boost the number that actually report on those PPI activities within their publications. And then lastly, this is sort of NIHR wide, but does apply to RfPB. Research inclusion is becoming more and more of a focus for the NIHR. And we're increasing the level to which research inclusion is outlined in applications and then also assessed. So it is becoming a condition of funding. At the minute, it's part of a soft rollout on RfPB, but is becoming more and more concrete with the way that we assess them. So matters on equality, diversity, and inclusivity are being assessed more and more by our committee and considered as part of the strength of an application. So I just wanted to take you through a couple of case studies of applications that have come through to RfPB, just to give you an indication of the kind of work that we fund, and even though it's for comparatively small amounts to other funding streams, you can see a really big patient impact and the trajectory to patient benefit from those. So the first of these is, and probably our most well known, is the Partner 2 study, which was an observational study to evaluate the effectiveness of antiretroviral therapy to prevent HIV transmission. This was led by Alison Roger from Royal Free in London and was funded for £341,000. And essentially what this sought to address were HIV infections amongst men who have sex with men, which amount to about £1 billion in future NHS costs. And at the time, there was a lack of evidence on the effect of antiretroviral therapy on the risk of HIV transmission between men who have sex with men. And several studies previously had showed that in heterosexual couples, the risk of HIV transmission was dramatically reduced if the HIV positive partner was on ART. So the study itself was an observational multi-center study with 75 sites across 14 European countries. They looked at 972 couples over 2 years and reporting risk transmission behavior every 6 months and providing blood samples from HIV negative partners every 6 to 12 months. And in terms of impact, the results of this were published in The Lancet in 2019, endorsed by over 1,000 HIV organizations in over 100 countries, and the evidence from the study underpin the World Health Organization and UNAIDS guidelines. And essentially reducing HIV transmission leads to improved public health and reduces NHS care costs. So this would have come through at what used to be our tier 1 limit of £350,000. And as you can see, sort of the results from the study could immediately impact clinical care and patient guidance. And then another one that we funded came through under our tier 3 guidance. This was funded in 2017 and sought to define obesity cutoff points for the risk of type 2 diabetes, cardiovascular disease and cancer among minority ethnic groups. And it used a prospective cohort study methodology using national linked health electronic health records. So in terms of this study, so WHO and NICE recommend a specific BMI cutoff to trigger preventative action to reduce the risk of obesity-related conditions such as type 2 diabetes and cardiovascular disease. And that cutoff of 30 was developed from observational studies in Europe and USA on exclusively white populations. And subsequent evidence indicated that adults from other ethnic groups developed type 2 diabetes at lower BMIs, and WHO recommended lowering the BMI cutoff to 27.5 for Chinese and South Asian populations based on sparse evidence base that might be inappropriate for some minority groups. So this study was the first to define BMI cutoffs for obesity based on the risk of developing type 2 diabetes in minority ethnic adults. And electronic health records from 1.47 million adults across primary care were linked to secondary care records to identify ethnicity-specific obesity BMI cutoff points for the risk of type 2 diabetes. And essentially, this was the first study to show that intervention should be triggered at a lower and different BMI for Arab populations and Black and South Asian ethnic subgroups. The results were published in the Lancet Diabetes and Endocrinology, and it's expected to eventually be reflected in the NICE guideline obesity identification, assessment and management guidance when it's updated. So, you know, for such a small amount of money, has really had quite a big impact. And this is one of the strengths of our program, is that, you know, you can come in with cohort studies like this for quite a small amount of money, and they can really sort of snowball into having a really large effect, and it's really positive of seeing work like this come through. So I just wanted to take you through the application process, in case many of you aren't familiar with sort of how an application to the NIHR and specifically to RfPB works. So we operate a 2-stage process. The stage 1 process involves a short form, short stage 1 form, and this is a formative assessment where the applicant completes the main sections of the standard application form for committee to triage applications and offer advice/support to all those applicants. And at this stage 1, you know, there isn't a whole lot of room in the application form to really detail your methodology strongly. You know, you need to just hit some key notes, and really what our committee considers when they review these are the relevance and importance to patients and the NHS, a good solid research plan. You're not overly detailed, but certainly robust enough, a clearly articulated trajectory to patient benefit, and one that's commensurate with the research tier funding as we talked about. A solid team to carry out the work that they're actually planning on doing. patient and public involvement has to sort of run through the application all the way from involvement in actually crafting the application itself, as well as actually being involved in the work as it would be carried out. We also want to see considerations of EDI. Has inclusion been considered in matters relating to the research that's planned? If it's a feasibility study, is there clear stop-go criteria, a signal of efficacy, and is there a plan to take the work forward? So is there a named research funder for the full trial? And then they also look at things like value for money and whether the cost is commensurate with risk. So, with that trajectory to patient benefit, is it clear from the amount of money being asked for? And then essentially what can be improved. So from stage 1 to stage 2, there would be about a 6-week process to get the feedback from the committee, take that on board, rewrite to a stage 2 application, taking into account the comments from the committee, and come back with the longer application. So part of our thinking when we review applications at stage 1 is it possible to revise the application within that 6-month period to allay any of those concerns. So when you come back with those concerns at the stage 2 process, that would be a revised stage 1 with then some other sections included, including a fully filled out finance section. You have 6 weeks to complete the stage 2 process, and then you get a lot more room in your stage 2 application to properly detail that that methodology, that background literature, the level of involvement of PPI, and also going forward inclusion research inclusion considerations. And then we sometimes send stage 2 applications for external review if they are above £300,000. So essentially for those tier 1 studies, those go for external peer review, to which you would get the comments, and then they're assessed by the committee as a whole, where they consider whether this proposal is fundable. So in terms of that assessment criteria, what are they looking for? So they're looking at the significance and potential benefit to the NHS and its patients. So what is the trajectory to patient, carer, service user benefit? What's the likelihood that this will lead to that benefit? And what is the likely scale of that impact? Then they also look at research quality. So is it an important research question? Is the methodology robust and based on sound scientific rationale? And will the proposed methodology answer the research question? They also want to see evidence of attention to issues of equality, diversity, inclusion. So, consider the patient population at hand. Is there actually an active research strategy to include those underrepresented groups, especially those that don't participate in research very much? It's all very well saying that you'll include these groups, but actually, is there a robust strategy to include them? And then also, has the research involved service users at relevant stages of the project? So as I mentioned, not just within the proposed work itself, whether there'll be PPI groups, but have they been involved in actually crafting the application? Has there been consultation with relevant stakeholders to make sure that this is a research question that is of interest to those service users? And then thirdly, value for money. So given the likelihood of achieving patient benefit, is this proposal costed in the right tier? And then given the likely scale of impact, does it provide value for money? So we assess applications on a 6-point scoring scale. 6, 5, and 4 would be a positive a positive score, where we would be looking to invite an application. I think probably the best thing is to know the sort of the lower bound of that. So in terms of what we could consider fundable, we would see we wouldn't be seeing a perfect application. We would be considering that there are faults, perhaps some major ones or minor ones, but the main thing is that these are fixable within that period of time after we sort of agree that a project should be funded, and then in its contracting stage. So in that matter of 2 or 3 weeks, based on responses from the application team, we can communicate the the comments and faults identified by the committee, and they would be deemed fixable within that time to adjust the research plan. So even at that stage 2, we're not expecting that applications will be perfect. There will still be things that will concern the committee, but as long as there is enough, as long as those concerns aren't too insurmountable, then we can expect that that could be funded at the stage 2. So as I was mentioning, RfPB is one of the, I suppose, friendlier research streams in the NIHR. So we see a success rate of about 20 to 22%. So over the 2023 to 24 period, we've seen 357 applications come through to the committee at stage 1. 123 of these, which is about 35%, got shortlisted to stage 2, and then about from those 80 were awarded. So that's about 65%. So really, I think what you should take from this is that the really big hurdle is stage 1. That's the really difficult one to sort of get in that first tranche of applications that gets through to stage 2, get that opportunity to really flesh out your proposal, and then at that point you have a 65% chance of being funded. Obviously not random, it's dependent on the quality of your proposal, but I think you can really take pride if you get through that initial sift at stage 1 with a strong application. You stand a really good chance of getting funded. So just to let you know how the application process works, so currently open is competition 56. And just to let you know what the sort of timeline from that point on to being funded. So we would see a stage 1 application be submitted before call close, which is the start of March, so within a month. We would then have the stage 1 committee meeting in May, where our committees get together and assess these proposals. We would get outcomes around July, so coming back to you to see if you would and then if you're successful, you would get from July to work on your stage 2 application, for which you would submit in, I believe, August. And then in September, again, we have another committee meeting that would be for the stage 2 applications. And then in November, you would have a decision. So essentially from March 2025, by the time you submit your application, you'll have heard from the start to the end of the funding process in November, which is about, let me do my maths, about 8 months. So, make sure you bear that in mind with your expectations of how quickly things will move. But yeah, you're looking at about an 8-month process from submission of your initial application to getting a decision on whether you've been funded or not. And obviously in between that, you'll have your stage 1 outcome and your stage 2 writing. So you will be kept busy. So we have some time here just to sort of go through what a good application would look like. So as I've sort of touched on earlier, we would expect applicants to identify a research question that has a very clear trajectory to patient benefit. When we're talking about that trajectory to patient benefit, we're not just saying, oh, this affects lots of people, therefore it's important. We would be expecting that applicants can sort of outline what the steps would be from doing this research to actually seeing change implemented in the NHS and considering whether also that would be feasible or not. We would want to see a structured, coherent and feasible research plan with a robust methodology based on sound scientific rationale. We want to see the right team assembled. So, is there the correct range of disciplines to carry out the work that you're doing? If you're doing a big trial, is there necessary trial methodologists? Are there dedicated statisticians in the team to actually do the necessary analysis and make sure the methodology is robust to do that? We'd also expect to collaborate with relevant stakeholders, whether that's service users in terms of PPI or whether that's professional groups who might be able to contribute to sort of forming the research proposal. And then we also want to see a clear dissemination strategy, not just the sort of standard, we'll aim to publish some papers and go to a conference or two, but a real dissemination strategy that can sort of demonstrate a tangible benefit to the group that you're interested in helping. So we over competition 51, we went through all of our feedback and sort of categorized each of the feedback for rejected applications at stage 1 and tried to sort of categorize where applications fell down. As you can see, the biggest one that people fell down on was methodology. So often this was really, I think when we look through this, the biggest issue was like a complete lack of detail of knowing how the planned research would be done. Stage 1 is tough because you don't have a lot of room in that application form to craft your application, but so there isn't a lot of time there isn't a lot of room to provide that detail, but equally you just need to make sure that it is clear that there is a robust methodology underlining these things and a broad outline of like the work packages that are planning to being done. So scientific rationale was the second biggest. So that was especially making sure you have a clear outline of what the problem is at hand, why it's important, and why your research addresses it. PPI was third highest, so making sure that there is that relevant engagement of stakeholders, of service users, of patients and the public, both before the application is crafted, and then also during the application itself and the planned work. And then a lot of the others, when we actually look through these, they are well spread across various different types, but of these, the biggest ones, recruitment strategy, timeline and FTE, and research team and patient benefit. A lot of these were due to the fact that it was regarded as too ambitious, and it just wasn't clear that the research was actually feasible within the time granted. So one of the things I would always say is, if you are crafting an application, try to be honest with how long things take. We have committees who have a wide range of methodologies, and they'll be able to recognize applications which are saying, an analysis plan will be able to be done in 2 months, whereas it actually would take 4 or 5. That would be identified by a committee and not looked on favorably. So always be honest and don't try and shortcut things to make your application look better. And then in stage 2, we did the same activity to look at stage 2 feedback, and broadly we saw the same trends. So again, methodology, that was nearly present in 17% of applications that were rejected. Even with the larger space in stage 2, making sure that you have a robust methodological plan with enough detail so that the committee can actually assess it is really, really important. And then again, same things with PPI, scientific rationale, and patient benefit. Make sure that trajectory to patient benefit is really outlined. What the follow-on steps from this are, and you can robustly say why that will eventually translate to patient benefit. And again, timeline and FTE, research team, outcome measures, all big factors in when an application has been rejected. The committees just haven't been convinced that there was sufficient time or detail to assess them. So yeah, as I mentioned, with the research question, our common points of feedback when in rejections are usually a failure to demonstrate the importance of a topic and how to reach patient benefit. Questions often ill-defined, unfocused, or unsupported by preliminary data. There's an omission of critical literature preferences and insufficient PPI in defining the research question. Similarly, with the research plan, detail of the intervention is lacking or too technical. The timescales are too short or too long and lacking justification, insufficient recognition of potential problems, and an inappropriate or unjustified costings. Simultaneously with methodology, as I sort of touched on, insufficient detail to allow the committee to assess the scientific quality of the proposed research, unsuitable methodology, which is flawed or unlikely to yield relevant results, inappropriate outcome measures, inappropriate statistics or health economics analysis, and concerns with recruitment, sampling, and overall feasibility. And then issues with the research team can sometimes include areas of expertise lacking. So often we've found that health economics and statistics can quite often be left off the research team, and you can notice that in an application. So by all means, make sure those members are included in your research team if you're including that kind of work. And then also senior colleagues included at 1% FTE without justification. We know that this is often used as a way of cutting costs on an application, but ultimately people who are costed in the application need to be able to demonstrate that the work that is sort of assigned to them can actually be completed with the amount of time that they're allocated in an application. And then other things to consider, as I've mentioned, PPI should be a constant thread throughout the proposal. So not only from the detailing the work involved in crafting it, but then also the activity during the proposed work as well. And then related to that, ensuring your plain English summary is clear and understandable, doesn't have jargon in. Often the best ones are ones that have gone through a public partner who've read it, either helped craft it themselves or at least have commented on whether this is understandable to the group. EDI, as I've said, this is becoming more and more of a focus now with the NIHR's focus on prioritization of this. So the research plan should make clear how inclusion and the impact on underserved groups have been considered in the proposed work. So, really thinking on those topics of inclusivity. And I just wanted to highlight that there is application guidance available online regarding the NIHR's focus on research inclusion. So there is a 45-minute webinar which goes into a lot of detail on how to craft good inclusion strategies and guide applicants in designing research to meet this EDI requirement. And as I mentioned earlier, with the dissemination strategy, that is vital to achieve patient benefit and should be specific to the output and thinking about how it could be integrated into care and practice. So for instance, if you were developing a new intervention, how are you going to publicize that intervention to the relevant groups to see that it is actually implemented into care and practice, or at some point can be how can you actually develop that interest? The dissemination strategy for that would be very different to one looking at doing a secondary data analysis, and we don't just want to see a sort of boilerplate dissemination strategy for all. So really think about all of these things are really important when crafting your application. I know it's a lot to take in, but it's always good to have those things in your mind when you're crafting one. So I also just wanted to highlight the research support service and how researchers are supported. So we have the RSS is a really, really good tool for you to consider going to, especially if you're quite new to research and creating your application. The RSS provides support and advice to researchers from all backgrounds and organisations in health and social care, not just to develop funding applications, but also throughout the research pathways, and not just during the funding, but also when you sort of get up and running and liaising between, can act as a liaison between you and maybe people who could help. So this is a service that's sort of developed originally from the RDS. It's sort of rebranded in the last couple of years to a national service, which is delivered by 8 hubs, and the service is based on expertise offered, not their location. So as you can see with the spokes, each one they're sort of based at 8 different hubs. And it's a partnership of research groups, organisations and clinical trials units with expertise in applied health and care research. 3 hubs deliver the core services and host specialist centres in social care. So that's in Lancaster, and public health, which is Newcastle and Southampton. I assume as the School of Primary Care Research, that will probably be of less interest to you, and you can maybe focus on these other 5 hubs. But each one, if you go on the RSS website, it sort of demonstrates which of the expertise each one has. So if you're looking for specific help maybe in crafting your application, you can sort of pick the hub that would be most relevant to the help you need, and they can help sort of go through your application, provide methodological support and things like that, and maybe also, as I say, sort of act as a liaison to bring researchers on board. So, as I said, by offering expertise in research design, collaboration and implementation, all hubs and specialist centres, regardless of location, can help researchers develop appropriate methodological approaches, plan projects, teams and budgets, plan for implementation and impact, improve writing techniques / pitching an application. I think that could be really important if you're an early career researcher and never developed an application before. They can really help you, write the application to make sure that you get the meaning across and making sure that you're addressing those points that our committees often look for. They can also provide guidance on including patient, public, service user and community involvement and engagement in the application, maximize equality, diversity and inclusion, and also think about collaboration and delivery of research. And what I would say is that we have RSS members who sit in on committees every meeting. So the RSS are really well integrated with our program. They know what we look for and they can help provide that advice to you. So ultimately, you know, they are a really good source of advice. And I think if you have, if you are planning a funding application, I would always recommend going to talk to the RSS just to make sure that your understanding of what us as a program are after matches with what you're trying to target in when you're crafting your application. These slides can be made available after the meeting. I've provided some links on here with the RfPB webpage, some guidance that we have for applicants, including funding limits, frequently asked questions, and also that inclusion webinar that I talked about. The other thing I would also recommend is that we operate a live mailbox. So if you have questions, if you are thinking about submitting an application and you have a small program-based query, things like, oh, I'm planning this application, but I really don't know if this would come in as a tier 1 or a tier 2 or a tier 3, you can get in contact with us on the RfPB mailbox. That's rfpb@nihr.ac.uk. We monitor that as PMs. Your email would go through to the region of the PM so it would go through to the mailbox of the PM of the region that you're in, and they would be able to help answer any question you have. So, I would always recommend getting in touch if you have small questions about the program like that, rather than just trying to guess and go through the process of submitting an application based on an assumption of your own, and then potentially seeing yourself rejected at stage 1, wasting 3 months of your time, and then having to start all over again when actually you could have answered it with quite an easy question from the PM. I'm no longer a regional PM, so I don't get these emails come through to me anymore. So I'm very happy to advertise these to all my other colleagues who do operate the mailbox, and you can spam them as much as you like with your questions. There's also a phone number, but I would just always recommend going through email, and they can also set up calls. And then there's also a link to the RSS that we talked about. So yeah, that's the end of my presentation. I think I managed to almost exactly talk for 45 minutes, which I'm very impressed by. So yeah, I will happily open things up for questions.
Hi, Nick. There are a couple of questions in the chat.
Great. Let me see if I can find that. There we go. Do projects on populations based within children's social care fit within the remit of RfPB, or do they have to be strictly based within the NHS? I mean, social care applications can be relevant to RfPB, but I think what I would recommend in this case is going to the research program for social care. That is a dedicated social care research program. It's sort of based very much on the RfPB funding model. A lot of it originally started as sort of like an RfPB funding program and then has become its own standalone one. I would really, really recommend going to RPSC for an application there, considering they have committees full of social care experts and will probably be better placed to assess an application like that. So that would be my recommendation for that. That's from Abisola Balagan. Rebecca Goulding, please can you restate how an ECR is defined in the context of being a lead applicant? Also, what would count as a sufficiently more senior colleague for a joint lead applicant? Yes, so sorry, I must have skipped over this. So an early career researcher is considered someone who hasn't led on generally an RfPB sized award before. So generally you'd be looking at if you haven't been a lead applicant on an application worth £100,000 plus, so that wouldn't include things like fellowships, but which I assume some of you will be on, as I know that the academy is highly linked with the schools. So if you haven't led on an application a sort of RfPB sized award, you would probably be considered an early career researcher. And then in terms of a joint lead applicant, we would be looking at a senior applicant who essentially has led on an award of that size. We would probably look for, I would probably say a few applications to make sure that, if you do encounter issues that are with the study, that there is that expertise within a joint lead applicant to provide advice, provide mentorship to get around those. We just want to make sure that we're not leaving funds in the hands of people who just don't quite have that level of experience to make sure that they can handle things come what may, and they just have that support available to them. So that would be reviewed as part of the capacity building things. Quick question. I'm an AHP, but not currently in a clinical role as I'm finishing my PhD. Am I still able to apply for the specialist AHP funding call if not currently working clinically? Unfortunately, the AHP call has just wrapped up, so that is no longer open, but we are always open to AHPs. The point of those underrepresented disciplines call is that basically those are always in scope. We just wanted to make sure that people had a sort of standalone opportunity to apply and sort of boost that profile that we do accept those applications. So if you are an AHP, by all means, just apply for one of our normal research calls. I think I might have overlooked this in the presentation, but a really important part of the program is that we only fund NHS bodies as a contractor. So there needs to be some kind of relationship between you and an NHS body, although that can be as simple as an honorary contract. So yeah, we would just be looking for that. Potentially, if you're unable to organise that as an honorary, even an honorary appointment to an NHS trust or a hospice or a clinical commissioning group or an ICB or something, then you could potentially be a joint lead applicant, and the lead applicant could then have that relationship with the trust. Alongside demonstrating the value for patient benefit within the NHS, is there any value in emphasising the possible international value of the research, or is it best to focus on UK benefit? So we are the priority of the programme is to boost the health and wealth of the nation, and very much focused on the English side of things with care. I think I would always try to consider that trajectory to patient benefit, considering you have so little room, especially at stage 1, to make that case for a trajectory to patient benefit. I think it is generally better to focus on the English care system and how it could be implemented there. Obviously, there are very different considerations as to whether things could be implemented worldwide or nationwide. And really what we want to see is there a realistic trajectory to patient benefit, to making a difference to people's lives in the UK. Obviously, if it is an international problem, that would be recognised as being very important, I'd say. But the sort of the main first step is always that we can definitely change people's lives in this country, and then by all means, if that can be transferable to other countries across Europe, Asia, Africa, America, then that's great. But I would make sure that you're initially, at least, your application is definitely well grounded in the fact that this could affect this could be like implemented and change practice in this country. Are researchers able to apply for a clinical salary level of pay within the fund? So yeah, you would have to be, so you would your salary would be based on your full-time equivalent, your FTE percentage that you would be assigned in your application. So the amount of full-time equivalent you're given, and that would be based on whatever salary you currently have. I'm sorry, this question is a bit complicated for me to think about. I think basically whatever your salary is, that would be what would be considered. And then it would just be a case of, what is the percentage of time that you're being allocated to that. Can you be costed as both a lead applicant and researcher if you're an ECR and have previously been a co-lead applicant? Would you be expected to apply as sole lead applicant or have a senior mentor involved? So, I mean, in terms of joint lead applicants, if you have led on a research project, even if it was, as that, so if you'd started off maybe had a successful joint lead application and then went and then we're thinking of a subsequent one, you could by all means apply as a lead applicant and no longer need a joint lead one. You're also very welcome to include a joint lead applicant if you want to. I mean, I think some people find especially in like mixed methods studies and ones that are very multidisciplinary, sometimes they find it benefit just to have even two experienced joint leads working together, just so that there is that benefit at the very top level of the application, that they can sort of direct that work and things. So you're not, if you've already led on a grant, £100,000 plus, the committee probably wouldn't think that you would need a joint lead applicant to work with you, but by all means, you can bring one on board. So yeah, hopefully that answered that question. Can you clarify what you mean by we only fund NHS bodies? So yes, so we only contract, so unlike other programs which sometimes contract with universities, we only contract with NHS bodies. So that could be things like integrate. So ordinarily, the vast majority are NHS trusts that we contract through. Often applicants will mostly be associated with a university, and then they just need to have some sort of employment relationship with the trust that they are applying through. But that trust, so it's not just trusts, it can also be integrated care boards, integrated care systems. I think clinical commissioning groups have now been disbanded, so I don't think they exist anymore, but hospices, certain hospitals as well. Basically, it would just have to be an NHS body that we would contract with. There is some more information online if that would help. And as I say, if you're only associated with a university at this point, and you want to lead on an application, then we would just want to see that there is some sort of relationship between you and the trust that you're applying through. So that could be in the form of an honorary contract, if that makes sense. Can you confirm if applications can be for research across the UK, or are they limited to England? So applications have to come from trusts and NHS bodies in England. We can accept studies that involve work in the UK. So like if it's a clinical trial and there are sites in Scotland, as long as the sort of contracting organization is in this country and the research is mostly based here, we can include things. So we do have some studies that, as I mentioned with Partner 2, that involved sites across Europe as well. So we can involve research that takes place outside of England, but the lead applicant and host organization would need to be in England, but research can, research can take place outside of this country. Is there wiggle room among the tiers with regards to inclusion in EDI? So if a project costs a wee bit more than tier 3/200K, yes, so this is a really good question. So as we're rolling out inclusion as being a condition of funding, obviously that means that there are certain levels of funds that will be required for doing that side of things. You can't just pretend that these things can be done for free, and that's fine. What we would expect is if we saw an application come through over tier 3, so if it's say developing an intervention, but it includes like some really good inclusion work and some dedicated recruitment strategies to make sure there's involvement of certain groups who maybe require that extra bit of strategizing to get them involved in that, and that increases costs. As long as that is well justified, we will consider it. We don't just have like this blanket, oh, you're looking at developing an intervention and you're 1 penny over tier 3. No, this isn't value for money. Goodbye. The committee judges value for money, and the tier 3, the research tiers are a guide to assist in that. If there are certain costs that need to be incurred that mean that research can't be delivered in there, they will obviously try to look to see if research can be delivered within that amount. But if there is a strong justification as to why you're above the tier limit by a certain amount, then that can usually be accommodated and be considered. Some funding opportunities have an upper limit, e.g. ST3 salary max. Yeah, as far as I'm aware, we don't have that limit. If a lead applicant associated with NHS and university, can they cost part of their FTE with the uni and the rest with the NHS? No, I think I wouldn't be able to say for definite, but I'm pretty sure that the FTE needs to be paid from one or the other. And that's what needs to be considered. And then obviously you have like the 80%, but there's a different level of contribution for universities and trusts. So I wouldn't be able to say for definite on that one. You might need to check the financial guidance or submit a query to the mailbox to get that one definitively answered. Sorry about that. I'm not so good on the finance side of things. Maybe we have our own separate department who help with that. Yeah, I can't see any other questions there, but feel free, if any of those people whose questions I have answered, if you feel I haven't answered your question, let me know. But otherwise, I would also really recommend, as I said before, of emailing the RfPB at NIHR mailbox. That's continuously monitored, and you will get through to someone if you have a query about an application to be submitted. But there's also a lot of resource on our websites to help. Hopefully most of the questions you have. But if anything's not clear on there, please do send us an email.
All right, thanks very much, Nick, for that.
Thank you.
That's really great. And can I just remind people that we do have our next masterclass in March, which is making your research accessible to people living with hearing loss and the deaf community. But again, thank you, Nick.